the problems, the causes, and hopefully some solutions we can learn tonight. So tonight's speaker is Dr. Cindy Tofthagen. I will introduce her here in just a minute. Just for your own information, our webinars are all archived, and you can find our previous webinars archived at fightcolorectalcancer.org/webinars. We will have a follow-up survey that comes out to you tonight after the webinar, and we send out folks a free Blue Star of Hope pin. If you can just take a minute and tell us how we did tonight, it's actually really important to us. And you can ask a question in a couple of different ways, and many of you have already asked so many questions. We already have so many here sitting right in front of us. But you can still ask a question on tonight's webinar on the right-hand side of your screen in the panel. Or you can call into our Fight Colorectal Cancer answer line at any point tonight or tomorrow or in the future, and that number is listed there at 877-427-2111. Our disclaimer, mainly just to let you know that the information and services provided by Fight Colorectal Cancer are really just for your general informational purposes only. And we do have, this is part of our monthly patient webinar series, and we have a webinar coming up in November that will discuss the advances in surgical treatments for both colon and rectal cancer patients. And that will be held on November 20th at the same time frame. And you can go to fightcolorectalcancer.org to register for that. And so it is my pleasure tonight to introduce Dr. Cindy Tofthagen. Please join me in welcoming her. She is from the University of South Florida. And I have to tell you, all those letters after her name essentially tells us that in addition to her PhD, she is kind of what I like to call all things nursing practitioner. She is an advanced registered nurse practitioner. She is an advanced oncology certified nurse practitioner, as well as a fellow of the American Association of Nurse Practitioners. So Dr. Tofthagen is an oncology nurse practitioner that's committed to improving the lives of people undergoing cancer treatment through her research, her clinical practice, and her role as an educator. She is currently an assistant professor and director of oncology and nurse practitioner concentration at the University of South Florida, where she has earned both her master's and her doctoral degrees. Her research focuses on chemotherapy-induced peripheral neuropathy, a very debilitating side effect of chemotherapy, which we're here to talk about tonight. And her research has provided a better understanding of the effects of neuropathy on quality of life of patients undergoing chemotherapy, as well as other cancer survivors. So as you can see, she is quite the expert on our topic tonight. So I really want to thank you for joining us tonight, Dr. Tofthagen, and I am going to turn things over to you both verbally and I'm going to give you control. And if you wait just a couple of seconds and move your mouse, you should be able to advance your own slides there. Oh, wait a sec. Hang on, let me take that back.
It just went away. Thank you so much for having me, Kim, and thank you for everyone for joining us tonight. It's such a pleasure to be here to speak to you. It's my favorite thing in the world to speak to patients and their caregivers, because this is such an important topic that is really under-addressed in cancer care. I see the screen now again.
You should, if you just move your mouse a little bit, you should be able to then advance them.
What do I press on to advance?
Your arrow down or your arrow up?
Not working.
No? Okay. Allow me.
That'll work.
There we go. How's that?
Okay. Thank you for that very kind introduction, Kim. as Kim alluded to, I've been in oncology for a very, very long time. Most of my career was actually spent as a chemotherapy nurse. And when I was a brand new nurse in 1992, I worked on a unit in the hospital where we would give chemotherapy, potentially neurotoxic chemotherapy, but we didn't see nearly the problems with chemotherapy related neuropathy that we see now. And so as time went on, I saw more and more patients having huge problems with neuropathy, and there was very little that we could actually do to help them. And so that's how it became my research interest when I was in my doctoral program, because it's really my sincere desire to make life better for the patients that have to endure this sometimes debilitating side effect, and often it's unexpected. And so that's a little bit about my clinical background that brought me to want to find solutions for this problem. Kim, you want to move it forward? Kim?
I apologize. Hang on just one second while we're having a slight technical difficulty.
Sorry, everybody. Thanks for your patience.
Trust me, it's not Dr. Tofthagen's fault. Hang on for 1 second while I work outside in advance. I apologize for the disruption.
Okay. Thanks, Kim. So tonight we're going to talk about three basic things. First of all, we're going to talk about what is chemotherapy-induced peripheral neuropathy, which we usually abbreviate CIPN. I might call it that. Sometimes I might just call it neuropathy, because chemotherapy-induced peripheral neuropathy, to mention it 100 times in a presentation becomes a mouthful. So I'll probably stick to short and sweet with that. And we're going to talk about the risk factors for peripheral neuropathy and how you can identify whether you have risk factors before you start treatment. Many of you may be already past that point, and that's okay. But it's good to identify what the other risk factors might be, because certainly chemotherapy is not the only cause of peripheral neuropathy. And then we're going to talk about strategies for dealing with it, managing it, coping with it, and living with it, because that can be quite a challenge. Kim? So exactly what is peripheral neuropathy? It's really a constellation of symptoms that affect both the nerves and the muscles, and they come about from nerve damage from specific chemotherapy drugs that we use in the treatment of cancer. And certainly colorectal cancer patients receive neurotoxic chemo often as part of their chemotherapy regimen. And one of the main offenders that causes neuropathy is called oxaliplatin or aloxatin, and it's part of a regimen of chemotherapy often referred to as FOLFOX. And chemotherapy-induced peripheral neuropathy affects roughly 30 to 100% of patients, depending on the drug and the dose that patients receive. And for patients who receive this oxaliplatin for colorectal cancer, it's usually about 60% of patients develop chronic peripheral neuropathy. There's also an acute neurotoxicity caused by oxaliplatin that we don't really put in this category because it's transient. It goes away after you're done with treatment, and it comes and goes in between treatment. And just to mention a little bit about this acute toxicity, most people will have sensitivity to cold temperatures, or when they touch something cold, get a cold drink out of a refrigerator, drink something cold, it produces an electric-like shock sensation in their body. And they also often will have numbness and tingling, or at least tingling, maybe some pain in the fingers and the hands and arms should they come in contact with something cold, which is pretty hard to avoid when you live up north. In Florida, where I live, it's not that difficult. But as I mentioned, oxaliplatin, there's a sister drug to oxaliplatin called cisplatin that patients that have other types of tumors, lung cancer, testicular cancer, those types of things receive. And then taxanes, which are given for most solid tumors these days. You've probably heard the name Taxol, that's a common offender, and Taxol's sister drug, Taxotere. So these are very commonly used chemotherapy drugs that affect all patients that have all the major cancers, including breast, lung, prostate, colorectal, and many, many others. And so this is a widespread problem for cancer patients and also for cancer survivors. Kim? So what exactly are the symptoms of peripheral neuropathy? Well, they're categorized into three different sections. Sensory, meaning they affect the way things feel and what you can feel with your hands and your feet as well, pretty much. So being able to detect or not detect sensation all falls into this sensory category. Motor means anything that affects your muscles, your strength, your balance, your ability to know where your body parts are in time and space. Is all lumped under these motor symptoms. And so the main problem that we see with peripheral neuropathy and motor symptoms is really loss of balance and muscle weakness in the legs particularly that can be problematic. Autonomic symptoms are less common in chemotherapy-related neuropathy, but they include all the things that we don't have bodily control over or voluntary control over, like our blood pressure, breathing, bowels, bladder. Those kind of things can be affected, not commonly, but sometimes in some patients. And so these can all be symptoms of peripheral neuropathy. The symptoms vary greatly from one person to the next and within different types of treatments. And so we know, for instance, that motor symptoms are probably more common in patients that get taxanes, and pretty much the symptoms of oxaliplatin are thought to be primarily sensory. So we know a little bit about how these things differ from person to person, but there's a whole lot that we still don't know about why certain people get worse neuropathy and that kind of thing. But in general, the things that we consider hallmark symptoms are numbness, tingling, and pain or discomfort in the upper or lower extremities. Usually it occurs in what we call a stocking glove pattern, which means it starts in either the fingertips or the toes, or it could be both, and it sort of works its way up through the fingers, through the toes, sometimes into the hand, or involving the entire foot, and then when it's really bad, up into the arms or the legs. So the more of your extremity is involved, really the worse that it is. Kim? Now, the problem with neuropathy is that for a long time, we told patients, and I have done this myself because we didn't really have the knowledge that we have now, is that this is a temporary problem. It's going to go away within several months after you finish chemo. And most of the time it does, but sometimes it doesn't. And some people have very severe neuropathy that is going to be a lifelong situation for them after they stop their chemo. And one of the worst problems is that it really interferes with patients' ability to do the things that they need and want to do in daily life. Kim? So basically, the more neurotoxic chemotherapy you get, the higher your risk of developing this problem. So people don't develop it normally after the first or even the second cycle, but the more you get, the more chance of developing it, and the more you get, if you don't do something about it, the worse it will get. Well, what can we do about it? Really, the main thing that we can do is reduce the offending drug or take it away and replace it with something that doesn't really affect the nervous system. And that's an individual sort of choice that should be made by your oncologist when that becomes an issue. And so definitely it's hugely important to let your oncologist know if you're having any of these symptoms that I described in the last slide. Also, patients often will get more than one neurotoxic chemotherapy at the same time. And so it's very common for patients to get, for instance, cisplatin and Taxol together in a regimen for lung cancer. And so that, of course, increases your risk. Diabetes is a huge risk factor. About 30% of neuropathies are actually caused by diabetes, and you hear about that most commonly. I think for most of us, when we think about neuropathy, we do think about diabetes, and there's very good reason for that. But so if you think about 30% of patients that have neuropathy, it's from diabetes. That means 70% it's from something else, and there are a variety of causes. Having underactive thyroid can also cause it. HIV infection, Charcot-Marie-Tooth disease, which is a genetic illness that you're born with. Many autoimmune disorders like rheumatoid arthritis and others can sort of mimic or cause peripheral neuropathy, and so we see a lot of problems in that respect. Also, common in cancer patients is vitamin B12 deficiency, and this causes neuropathy. It also can cause cognitive changes, so people's short-term memory can be impaired, and sometimes they think that that's chemo brain. So sometimes it's hard to detect what the actual cause of these problems are, but a simple blood test will tell you if you have a vitamin B12 deficiency, and if so, that can be easily corrected with replacement, either oral or IV. But it's not something you want to take on your own, because even though a lot of people do use vitamin B12 on their own, it can sort of affect your other counts, and it might not be something that your oncologist would recommend you do without a documented deficiency. Also, a chronic alcohol use can cause peripheral neuropathy, and then also very common in cancer patients is the shingles that people get that can leave long-lasting neuropathy type pain. Kim? So I was giving a talk at a seminar on peripheral neuropathy in the Tampa Bay area, and I met this wonderful lady whose name was Sue. And I guess that this was, when she heard me speak, she came up after me and she had tears in her eyes, and she said to me, "Wow, thank you so much for coming and talking about this, because this is the first time anyone has actually really acknowledged what I'm going through. I go to my oncologist and I tell them about all the problems I'm having from chemo I got years back, and I get the impression that they don't really want to hear about it, or they don't know what to do about it, or they think I should just be grateful to still be alive." But she said it's affected my quality of life so much. And she said, they told me that the chemotherapy increased my chances of living 5 years by 8%. She said, "I don't want to live another 5 years like that. My hands and fingers are numb, my feet are numb, my legs are numb. I have pain, gnawing, burning, cramping most of the time, and my legs are achy and stiff and heavy all the time. I can't walk, I can't drive. Being on my feet is a problem. My hands don't work. I feel dizzy and weak every day, all the time. I have disabling fatigue, and I feel like I've been poisoned." And this was really one of the first articles that I published from the patient's perspective, because I feel like, as somebody that does research in this area and that has the attention of other healthcare providers, it's important for me to give a voice to patients like Sue. So we published her story because happened to her. And so the article that we published just tells about her story and how it affected her quality of life, because I just thought it was important for healthcare providers to understand, because I think it is definitely under-recognized and under-addressed. Kim? So this is what we call in academia a conceptual model of how I view peripheral neuropathy, and it's kind of distinctive because usually when you hear about neuropathy, people only focus on the painful aspect. And chemo-induced neuropathy is not something that patients will, even the majority of time, describe as painful. But the thing that is very bothersome that doesn't cause pain or discomfort is this loss of sensation. When you cannot feel your feet or your hands, then it creates so many other problems, particularly functional disabilities, or, like I said, inability to do the things that you want to do in life. And so this combination of lost sensation and hypersensation, patients that do have pain can have pain from unusual causes. Maybe they're laying in bed and for no good reason their feet start to burn or throb, or a sheet causes pain when it ordinarily would be something comforting, or their feet get so cold that they feel like they're ice cubes. These are things that people have described to me that are unpleasant and uncomfortable, but patients don't necessarily recognize as pain. But this triad of loss of sensation, exaggerated sensation, and functional disability is really the totality of peripheral neuropathy. Kim? This slide is actually from one of the early studies that I conducted, just talking to patients that I knew had chemotherapy-related peripheral neuropathy about how it affected their daily lives. And so you can see that they reported that their neuropathy symptoms interfered with basically every aspect of their life, from the things that we know of, like being able to pick up objects or zip their zippers. We've known that stuff for a long time, but what we've only really started to crack the iceberg of is how it affects things like, their enjoyment of life, their relationships with other people, their sexuality, their ability to sleep at night. All of these things can be affected by peripheral neuropathy when it's severe. Kim? So we don't have a cure for CIPN right now. What we have is the ability to, first of all, recognize patients that are at high risk and intervene before we give them chemotherapy by choosing less neurotoxic regimens, if that is indeed an option that would not compromise efficacy of the chemotherapy drugs. And also there are some new techniques that we'll talk about in terms of prevention, and the majority of research in the area now is going toward preventing it, and I think that's key, because my area of research is not in prevention but in helping patients manage it after the fact. And if we can prevent it at some point, then we won't have to do that, and patients will be able to get back to their original quality of life sooner after their treatment. The second thing that is very important is to recognize it early. Also, if there's pain involved, to control the pain, and it can be controlled. And also, very important is to minimize the effects of the neuropathy on quality of life. Kim? So how can it be prevented, or what sort of things have been studied? Now, I have a list here that has several things, and some of them you may have heard of, you may have tried yourself. Calcium and magnesium infusions have been shown repeatedly in clinical trials and in meta-analysis to prevent peripheral neuropathy in patients receiving oxaliplatin only, not with the other types of drugs. And there is some conflicting evidence, because some studies included a lot of patients that were getting other drugs, and so we're really not sure of those effects. But we can say with pretty much certainty from the clinical trials that it's not harmful and that it may help lessen the severity of peripheral neuropathy. And so that is something to consider if you either are beginning your treatment or you're talking about getting treatment with chemotherapy. Alpha lipoic acid has been investigated, and we'll talk some more about that later. B vitamins there hasn't been much research done, but a lot of practitioners will recommend patients take B vitamins when they develop neuropathy because it's thought to protect the neurologic system in some ways. But with all of these agents, most of these outside of calcium and magnesium are available in the health food store over the counter. I do not recommend that you take these routinely because some of them can have some sort of interactions with your chemo or dangerous sort of side effects. You really need to let your oncologist and the rest of your medical team know if you want to consider taking one of these agents and get their approval beforehand. But we'll talk about them a little bit more individually. Kim? So, like I said, with calcium and magnesium, these results have only come to light over the last few years, really. But there are now numerous trials that support their use. So if you're going to be put on chemotherapy or if you're in the middle of chemotherapy, this is something that you might want to have a discussion with your oncologist about. And as I said, we grade peripheral neuropathy or measure it in many ways. And grade 1 is kind of the lowest or the least severe form, and grade 2 is more severe. So what the calcium and magnesium infusions did in the clinical trials was to increase the severity of the neuropathy, but not the overall incidence of it. Kim? I think this slide's a little bit out of order, but that's okay. Genetics probably play an important role, and we're just beginning to scratch the surface of this. We don't really have much understanding of it yet, but certainly genetic alterations and variations can affect the metabolism and elimination of the drug and the way our body utilizes it. And so scientists in the basic sciences are right now looking at these genetic variances that may predispose certain people to get more severe neuropathy. And if we can do that, then we can potentially come up with some screening tests to identify patients at high risk before they ever start chemo. Kim? So it's important to recognize early, as I mentioned before, and to let your oncologist know at the very first sign of these symptoms, because if we can intervene early and reduce the dose or change out the drug if need be and something else is available that would be effective, then we can sort of lessen the severity and the long-term side effects of neuropathy. And so a lot of patients don't want to tell their oncologist when they have neuropathy out of fear, because sometimes it's really scary when you're on a chemotherapy and it could be working for you to sort of make yourself vulnerable with the potential of changing the drug. And so a lot of times patients don't tell us until it gets severe, and that's really not a good approach, because your oncologist knows that treating the cancer is of utmost importance, and they're not going to discontinue the drug unless it's absolutely necessary. And the impact of small dose changes that may affect the neuropathy may have very little effect on the way that it treats the cancer. So it's an individualized thing, but it's so important to have that open communication with your oncologist. Kim? So what kind of things do you need to tell your healthcare team? First of all, you need to tell them what symptoms you're having specifically. And as I mentioned about the stocking glove distribution, when you mention it, you want to say something like, I have numbness and tingling in my fingertips, and it extends down into my fingers a little bit, but it doesn't go up into my hand. And you also want to tell them if there's one side or both sides affected. Typically, chemotherapy-related neuropathy is bilateral or affects both sides. If only one side is affected, that could mean that there's something else causing it. And so there probably needs to be some additional evaluation done. We talked about how much of the extremity is involved. You also want to tell them how severe and distressing each symptom is. Okay, so everybody's used to using this 1 to 10 or 0 to 10 scale to indicate how severe a symptom is, and you can use that as a starting point. I have burning in my feet, and when it's bad, it's an 8 on a scale of 0 to 10, and that will be helpful to the people that are taking care of you. You also want to tell them if the symptoms are constant or if they come and go, and if they come and go, how long they last. And perhaps more importantly, or most importantly out of this list, they're all important, but they really need to know how these symptoms are affecting your lifestyle and your daily activities. Kim? Controlling the pain. So if you have painful neuropathy, you probably know that it is very difficult to control and often severe, and normal pain medicine doesn't work well for it. Kim? But certainly neuropathic pain can be controlled, and you have a right to adequate pain relief. And so often the people that can give you the best sort of guidance about what to do for your pain and can help you the most are pain management specialists. So if you're having a lot of pain and you've been working with one of your doctors to try and get control of this nerve pain and it's not working, ask for a referral to a pain management specialist. And when you talk to your doctor about your pain, these are the things that you want to tell them. Onset means, when did it start? Did you develop it 2 weeks ago, last night? When did it start? Where is the pain specifically? And we've talked about that already quite a bit. Duration means, how long does it last? And we talked about that. Characteristics, what does it feel like? Is it aching? Is it burning? Is it stabbing? Just give it some words to describe it the best you can. A lot of times it's hard to describe neuropathic pain to patient or to people, but try to come up with some words, because that will be helpful in guiding your treatment. Also, what kind of things aggravate it or make it worse or bring it on? And what kind of things have you tried that might have provided you some relief? Kim? So really, one of the most recent studies looked at duloxetine, which is also called Cymbalta, and many of the drugs that they use for neuropathic pain have not been studied extensively in patients with chemotherapy-related neuropathy. They may certainly work, but duloxetine or Cymbalta has more scientific evidence to support that it diminishes pain specifically from chemotherapy-induced neuropathy, improves function, and improves quality of life. And so this would be a good choice for many people if they don't have any contraindications or any reason that they shouldn't take this drug. So I really just wanted to make you aware of this. My colleague at the University of Michigan, Ellen Lavoie Smith, did this clinical trial with 220 patients, and this is what they found. Next. These are some guidelines from one of the pain societies about treatment of neuropathic pain, and I included this so that you could see that there are a lot of options and they can be combined when need be. Of course, this is not something that you would undertake on your own, but you would work carefully and closely with a physician to find the right drugs and the right doses that work for you. A lot of times when patients have neuropathic pain and they go to the doctor and they receive a prescription, they don't really understand that there might be dose changes that are necessary, or that that particular drug may not be the best choice for them. They go home, they try it. If they don't get immediate relief, then they stop taking it. And it's better to just let your team know what's going on so that they can further help you, because I've had patients that I've seen that I give them something for their pain and it doesn't work, but they don't tell me until their next visit, and then they're in pain for a long time, and that doesn't have to be the case. So the first line treatment is actually drugs that affect the neurotransmitters and also can be used for treatment of seizures. Gabapentin, which is also called Neurontin, and pregabalin, which is Lyrica, and I'm sure you've heard of those two drugs. But again, to really cause relief from pain, sometimes quite large doses are needed, but it has to be, we say, start low and go slow, so gradually escalated over a period of time. Then tricyclic antidepressants are another category of drugs that are considered first-line treatment. So you don't see pain pills up there as first line. They're down here as third-line treatment. Serotonin norepinephrine reuptake inhibitors are another class of antidepressants that can be very helpful in treating neuropathic pain. And also locally, if you have a very small area of pain or it's in one spot, you can often use a lidocaine patch or other sorts of topical applications that will provide you some relief. Kim? So I've listed some of the drugs that are used and what the usual starting dose, how often it should be titrated or the dose adjusted, and what the maximum dose is, and then how long you should give it an adequate trial, by slowly increasing the dose. So you can see that it would take some time to really be able to say for sure that this drug isn't going to work for you. Anywhere from 3 weeks to 8 weeks in that time frame is, really how much of a trial you should give it. Again, in constant communication with whoever's prescribing it to make sure that you're escalating it as is appropriate. Kim? Minimizing the effects on quality of life. Very important. So one of the studies that I did looked at falls in people with peripheral neuropathy, and we were looking for predictors for falls. And we found that, as with other types of neuropathy, falls were a pretty common occurrence. And they were really related to cycle numbers. So the more cycles of chemotherapy a patient had, the more likely they were to fall. And also, if they reported that they had loss of balance. It's kind of common sense, right? Patients often know when they're off balance, but we need to listen to them because certainly falls and the injuries associated with it can be huge and cause breaks, and patients can break a hip or another bone that can sort of put them out of commission for a long time. Kim? So neuropathy in the feet is very, very common, and it's important that you take care of your feet well. And it's kind of like with diabetics. If your feet are numb, you could have an injury on your foot and not even know it. So it's important that you wear comfortable shoes that fit you well, and that you try to avoid sandals and open-toed shoes and that kind of thing. And that's a temptation. I see a lot of patients that come in with slippers on, or flip-flops, and that's because that's what feels comfortable to them. But you have to be aware that if that's the case, you're sort of exposing your feet to possible injury. You should look at your feet every day to make sure that you don't have anything going on down there that you're unaware of. And check for stuff in your shoes before you put them on, because sometimes you might have an object in your shoe that you've been walking on for some time that could cause an abrasion or an ulceration or something like that, and you wouldn't know it. So tip out your shoes and shake them out before you put them on. And also, changing your shoes in the middle of the day is a good idea because different shoes create pressure in different places. And so, your shoes might feel good on your feet, but they could be causing pressure in places that you're unaware of with the numbness. Kim? So safety is a huge issue, again, because, falls are one safety topic in patients with neuropathy that's important, but patients can sustain bad burns and other sort of what we call thermal injuries. So precautions that you can take to avoid that, and should, are adjusting your water temperature to a maximum of 100 degrees to avoid injuring yourself when washing dishes or in the shower or bath. Always run the cold water first, which everyone should do anyway, and always use pot holders or protective gloves in the kitchen. And if you want more safety tips, I have a lot more, but I thought I would just give you some of the basics in this presentation. Kim? So keep the areas well lit, especially at nighttime, you know, when you get up, because what happens is neuropathy can also affect other parts of your sensation, but a lot of times we use our eyes and our vision to compensate for the lack of sensation. And so when it's dark and you can't use your vision to compensate, you're more at risk of falling. And also, it's important to use those non-skid mats in the shower or bathroom, and just to make sure you don't fall in the shower. I've had a couple of patients that have fallen in the shower from, you know, with their neuropathy. These are some other sort of tips that you can use to make your environment as safe as possible. And I'm not going to read them all because we're running a little bit short of time, but certainly go through these and kind of check your home. Another thing that can be useful is home health agencies often offer a home safety evaluation, and you can get a prescription from your healthcare provider for that, and they'll come out and inspect your house and give you some recommendations as to how you can sort of safety proof it for your own needs. Kim? I wanted to go over a study that was done with patients that have HIV related neuropathy, because this was a novel study because it basically talked to 450 patients about things that they did at home on their own to help relieve their symptoms. And so if you haven't tried some of these things and you're suffering with neuropathy, it might be helpful for you. Patients often tell me, and I've actually published some data too, that keeping warm is very, very important to relieving the symptoms of neuropathy. And this confirms that, because 66% of patients thought that warm baths were helpful. Walking or other types of exercise can be quite helpful. Massaging the area, rubbing cream on the feet, keeping your feet elevated or staying off of them, all can be very helpful. Acupuncture is another thing that there's not a lot of scientific evidence to support, but some patients do find it helpful. And meditation also was something that patients reported obtaining relief from. Kim? Exercise. Okay, now we've talked about how patients with neuropathy are at increased risk for falls, and there are specific exercises that people can do to increase their strength and their balance, and that can result in fewer falls. Many studies have demonstrated the safety of patients with neuropathy being in these type of exercise programs, and so it is safe. And something that's available in many, many communities is Tai Chi. You know, you can kind of look that up in the phone book and find a Tai Chi course, but it's really this low impact Chinese art that can improve your balance tremendously. Also, physical therapy is very helpful, and physical therapists are experts at finding the exercises that will work for your particular needs. Kim? So there are a variety of people that can help you to cope with and control neuropathy symptoms. It's not just one person. But if you haven't seen a neurologist and you have symptoms of neuropathy, it wouldn't be a bad idea for you to go see a neurologist to just confirm that the neuropathy is most likely related to chemotherapy. Because as I said, there can be many other causes, and the treatment could depend on the underlying cause. As we discussed, pain management is critical if you're having pain. There's a specialty called physiatrists, and these people are kind of rare in the country, but they're physicians who specialize in cancer rehabilitation. And so I gave you a website where you can look and see if there's one of those physiatrists in your area, because they can be tremendously helpful. Also, as we mentioned, the physical therapists can help you design an exercise program that meets your needs. and occupational therapists can help you maintain your independence by giving you suggestions and helping you find devices that will help work around the things that are affected by your neuropathy. For instance, maybe you are having trouble bending down and picking things up off the floor because you lose your balance. Well, you could get one of those little grabbers or reachers to help. But occupational therapists have so many tricks up their sleeves, and they're so underutilized. So, this is another area where you can get some help. Certainly, support groups and mental health professionals are key, because if you have a chronic condition like neuropathy, and for that matter, like cancer, you can have problems with anxiety, depression, coping skills sometimes are affected. And so sometimes it just is helpful to talk about it with somebody that will listen, and also with other people that have been where you're at. And so the Neuropathy Association is a wonderful organization that has 150 support groups all over the country, where you can just go and meet with other people that are going through similar circumstances. I actually lead a support group here in Tampa, and the members, I have some members that have been coming faithfully for 4 years, and they come not because of what they can get at this point, but for what they can give to the new people coming along. And then podiatrists can be very helpful, because there are certain sort of inserts for your shoes and orthotics that can really help sort of even out the pressure on your feet when you walk, and also keep you from developing injuries. And they can also recommend the best type of footwear for you. I wanted to tell you about some of the resources that may be available in your community. And so every community is a little bit different, but I tried to sort of give you some of the nationwide ones. The Live Strong program at the YMCA is a free program for anyone that has had cancer, and they will help devise an exercise program for you. For instance, if your insurance doesn't cover physical therapy, or it's easier for you to go to the gym, this would be a great program for you. And again, it's free of charge. Gentiva Home Care has a program that's specific home-based strength and balance training for people over 65 years old. And you need a referral for that from your physician, but this is a great program that's available in many, many places too, called Safe Strides. And then I mentioned the Neuropathy Association. They are the largest nonprofit provider of education and support for people with peripheral neuropathy from any cause. And so they're a valuable resource in the way of information and support. And next. So just kind of to wrap things up and summarize what we've talked about. Neuropathy can be very uncomfortable, distressing, interfere with patients' abilities to do the activities that they want to do, need to do every day. Next. Really, there's a whole lot of attention right now being given to chemotherapy-induced peripheral neuropathy. I've been doing research in this area for about 7 years, and when I started, there was hardly anything being looked at in terms of research. But now we've got a whole cadre of scientists working on this problem, so there is hope for being able to prevent it in I'm hoping, the very near future. But in the meantime, we have survivors and patients that are dealing with symptoms, and so it's important that we focus on their needs too. And definitely you can get control of your symptoms and their effects on your quality of life in many ways, but it's important to be aware of the options that are available in your community and for treatment, and to communicate very closely with your healthcare team, and to find the resources that are appropriate for you within your community. I think that's the end. Questions?
Well, that is the end of your presentation. Yes, it is not the end of the questions, though, for sure. Thank you so much.
I took
We've
too
had
long. I'm sorry.
no, no. It's it's great information for you to be able to share, and all of your expertise is very much appreciated. So let me just jump right in with one of the last bullet points that you just addressed when you were talking about magnesium and vitamin E. Are treatments like that useful only during or in only prevention of neuropathy, or can they be helpful while a patient is experiencing it, and can they be helpful years later after a patient has already finished therapy?
Yeah, that's a good question. And the short answer is we only have evidence to support its calcium and magnesium infusions as a preventative. The vitamin E is an option that might help certain patients in certain circumstances, but there's, limited evidence to support. There is some evidence. The B vitamins and things like that, all those things that I had listed are sort of what's in the pipeline that may help patients, but we're still investigating, with the exception of the calcium and magnesium infusions, which are IVs that you get right along with your chemo and that your doctor has to prescribe. We don't have any evidence that taking a calcium and magnesium pill has the same effect.
Okay, so IV magnesium and calcium, good. A pill of magnesium and calcium, still not sure.
Right.
Okay. Okay. And then along, staying with the vitamins there, what about large amounts of B1 and B12? Can you just recap? Does that help people or not?
If you have a vitamin B12 deficiency, vitamin B12 supplements may be helpful. It's very common for patients to take vitamin B12 proactively without any documented B12 deficiency. And, that may be okay to try, but again, it's something that you would really want to talk to your healthcare providers about, because they have different philosophies about which vitamins could be harmful to patients with cancer and undergoing chemotherapy. And for most sort of nutritional supplements, including vitamins, we do not have a lot of information about how those might react with the chemotherapy drugs.
Okay. Let's see. I'm going to summarize about probably 6 or 7 questions here in one question, and it's what I will use as someone called the question of the year. Um, Peripheral neuropathy. This patient's had it for 6.5 years, this one for 9 months, this one for a year and a half. The big overarching question is, does it ever actually truly go away?
If it's going to go away completely, it's probably going to happen within a year after treatment. That's not based on any research, but based on my own clinical experience. Most of the time, if it's going to go away, it's going to go away in about a year. If not, you're probably going to be dealing with it on a very long-term basis.
Okay. And so there's a couple of questions that relates to something called Scrambler Therapy, which is I don't know if it's Calmar or Calmari. Are you familiar with that type of treatment?
No, I'm not.
Okay.
Sorry.
That's okay. There's actually a couple of them here, so if anyone's on the line who asked those questions, we have a little bit of research on it here at Fight Colorectal Cancer. I know who submitted those questions, and I'd be happy to send you out at least, the information that we have on it.
That's great. Thank you, Kim.
No, sure. It's kind of a new thing that we just learned about from one of our medical advisory board members, so we're thankful for that. One of the things you did talk a little bit about this tonight, but I just want to make sure we address this particular question. What are some of the pluses and minuses found from using Lyrica? And I know you
Um,
mentioned Lyrica, but did you address some of the pluses and minuses?
sure. And that's a good question. Lyrica and Neurontin are drugs in the same class, and they're very similar. But Lyrica is time released, whereas Neurontin is not, and it provides a steady state of medication in the blood. Where Neurontin, the levels in the bloodstream go up and down rather erratically, and so theoretically, Lyrica would be a preferred drug just because of this steady state in the bloodstream. Also, usually you can take, or often you can take Lyrica twice a day, whereas Neurontin you have to take more frequently. And there is a whole bunch of data, particularly in diabetics, to support Lyrica. I think, because it's a newer drug and there's been more research on it more recently, we've got a lot of data to support its use. Um, I the drawbacks of Lyrica are that, first of all, many insurance companies will not cover it unless you've tried Neurontin first, or gabapentin, because gabapentin or Neurontin is cheaper than Lyrica. So cost is maybe a concern. So that's pretty much my take on the differences between the two drugs.
Okay. Uh, so this is kind of interesting. What about a patient who's experiencing neuropathy in their hands but not in their feet? Is that common? Does it normally affect both extremities, or?
It it usually does affect both, more the feet than the hands, but it can affect just the hands, and sometimes it just starts out in the fingers, and then eventually it can move into the feet.
Okay.
But one thing that people often do sort of get mixed up is that acute neurotoxicity that primarily affects the hands and really rarely affects the feet at all.
Okay, so if you could talk about that just for a second, what is the difference between acute neuropathy and chronic neuropathy? Because I think that a lot of the questions, some of them have to do with acute neuropathy and some of them have to do with chronic. So what is the
Yeah.
difference between the two?
Okay, so this whole line of conversation is only in respect to oxaliplatin, because that is the only drug that has this acute neurotoxicity associated with it. The other drugs that we mentioned, cisplatin, Taxol, Taxotere, other drugs that cause neuropathy like the beta alkaloids and other types of drugs, this just does not apply to. But if you're getting an oxaliplatin based regimen, and most people that get chemo for colorectal cancer do get oxaliplatin, right after your treatment for 5 to 7 days, you more like almost 100% of patients have this sensitivity to cold, where if they touch something that's cold or they're in a cold environment, they can have electric like sensations primarily in their hands, but also inside their mouth, in their throat, those type of things. And so we always recommend that they avoid temperature extremes, particularly cold, for a week or so after their treatment. But usually this regimen is given every 2 weeks. So there's, half the time they have to stay away from the cold, or they're going to have these things that could mimic chronic neuropathy, tingling sensations, pain, and that kind of thing. And then it goes away for a week, then they get their treatment again, and it starts again. And sometimes towards the end of the treatment, it lasts longer. But if it goes away within 5 to 7 days, then that's the acute problem. If it's in your feet or it doesn't go away, then it's probably the chronic kind. Another sort of consideration with oxaliplatin that is sort of unique, cisplatin is the same way, but there's a phenomenon called coasting, which basically patients may not develop symptoms until they've finished all of their chemotherapy. And sometimes maybe a month later they come back and they're starting to develop problems with neuropathy. And so that's another thing that we see. So if your chemo's done and you're having problems, that's definitely the chronic type. If you're still undergoing treatment, some of it could be the acute side effects.
Okay, I'm going to try and squeeze a couple more in here, so thanks for hanging out with us here.
Sure.
So oxaliplatin caused a painful neuropathy in one of the attendees in the balls of their feet, making it difficult to walk. Is there
Yeah.
any way to actually reduce the swelling, whether the swelling of the foot or the nerve swelling?
Yeah, well, some of that could be from inflammation of the nerve as well, and that is a very common problem. And in terms of how that feels and the pain associated with it, again, you can get control of the pain. You just have to work with the right person that's going to be, available to work with you on that. But and walking certainly can trigger pain in most patients. So can standing for long periods of time. So you kind of have to, in terms of how you cope with that, you have to plan accordingly, and sort of, take frequent rest periods, or so that you don't have to stand up for long periods. In terms of swelling, I don't know of any specific drug that would decrease the inflammation in the nerves themselves. But again, pain control is really important there. And if you have better pain control, you're going to be able to function better and walk for longer distances or stand for longer periods of time.
Okay, and so this is kind of related. So I'm going to actually lump two questions together here. One of our attendees has, it appears as though their neuropathy is almost spreading, like you mentioned earlier. It's going from their feet to their calves. So it's
Mm-hmm.
kind of moving somewhere in their body. And then another attendee has it kind of lessening in their hands, but not in their feet. So
Yeah.
how and why does it move around the body like that?
Well, I'm not sure exactly why it's I mean, I don't really view it as moving. I view it more as progressing or regressing. So, and the hands usually will go away first. So if you have it in both your hands and your feet, more than likely, if it's going to go away, it's going to go away first in your hands, and then you're going to have some residual in your feet. If it's moving up, then it's getting worse. If it's moving down, then it's getting better.
Interesting. Okay. Okay. Let's see. So so patients living with this, should they push themselves through the day and push themselves to do things and then just kind of suffer with what an attendee calls screaming feet at night, or should they really just back off and make adjustments to what they're doing during the day, or what would you suggest? What do you encourage your patients to do?
Well, it's kind of a vicious cycle, right? Because if you just sort of back off and you don't do things, and that has such an impact on your emotional well-being and how you feel about yourself and your life. If you it gets to the point where you can't really continue to push through it, and that's when really, I can't stress enough how many people just sort of suffer through the pain, and it can be controlled, and but it's a process and it takes time. So patience and persistence is key to success in this area. I had a patient who was a gastroenterologist, as a matter of fact, and he developed advanced colorectal cancer, and he had surgery, and then he got chemo, and he was fine through his chemo, and then at the end he developed severe neuropathy, and the neuropathy was so disabling for him that he had to close his GI practice, not because of his cancer, but because of the neuropathy. Later on, he was able to go back to work, but he had to adjust. So he used to, do colonoscopies and endoscopies and other procedures standing up all day long. And then when he went back to practice, he elected to not do those procedures, but to see follow-up patients in the office instead. And so, he was able to sort of work around them. So you have to sort of think creatively about what might work for you, or what you can change about the way that you're doing, so that you can continue to do the things that you want to do. For him, his whole sort of sense of fulfillment and who he was as a person, a lot of that was wrapped up in his role as a physician. So for him to lose that was, had such a negative impact on his self-esteem and his feelings of self-worth. So the fact that he was able to figure out a plan and adjust a bit, and get back to work was so important to him.
Right, so just kind of paying attention, doing what's important for your lifestyle too, which, can be hard, I'm sure, if you're dealing with something like this,
Oh
but
yeah.
still important. Okay, I'm going to try and squeeze in just three more. What about your experience in neuropathic pain that doesn't appear to be related to chemotherapy? I mean, is that too big of a thing is it too big of a question for you to address? Are there
Well,
like what other types of things cause neuropathic pain?
many, well, shingles, like we talked about, is one thing that often causes it, but many surgeries that people have for cancer, when you cut someone, you're often cutting nerves or damaging nerves. People that have surgery for lung cancer, they can have a lot of neuropathic pain at the surgical site. Also, people that have mastectomies have a lot of neuropathic type pain at the surgical site. I think really anybody that has, a fairly large incision can develop neuropathic pain as a result of that. And so it neuropathic pain has many causes, just like peripheral neuropathy. The pain is just one aspect of neuropathy, but people can have neuropathic pain that don't have peripheral neuropathy, so to speak. It's just, localized to their incision. So, again, it often requires several drugs to control or higher doses than sometimes your GP or other provider might feel comfortable in prescribing. And so finding somebody that knows how to manage pain and can utilize different aspects of it. There are some interventional techniques that can be very helpful. Nerve blocks and less invasive techniques are more and more common these days. So, sometimes that whole interventional piece where somebody's going in and doing a procedure to relieve pain can be scary to patients. It sounds scary to me, but they have some new techniques now that are very non-invasive but still can provide a lot of relief. So you really want to get in with somebody that has those expertise that can, say what's really, what's most likely to work in your individual circumstance, rather than just sort of toughing it out or suffering with it long term.
Okay. We talked a little bit about, calcium and magnesium and the time period that it's utilized best in. But if it ever worked for a patient, why do you stop it?
Well, after your chemo stops, typically you're not going to go in and get IV infusions of calcium and magnesium. Um, and that's probably a big area for future research. So, we I haven't seen any studies, not, there could be certainly studies that I haven't seen that look at it in the post chemotherapy phase. I'm not aware of those, or that's been done. I have had talked to patients that tried taking oral calcium and magnesium on their own, so to speak, and sometimes we try things that we think aren't going to hurt that can help, that may not have a lot of evidence to support, and that's okay. And that, the calcium and magnesium may fall in that class, but you definitely want to get some input about how much you should be taking and whether it's a good thing for you or not based on your individual health situation.
So be sure and talk to your doctor or your nurse about it.
Absolutely.
Um, And so last question, part A and B. What you had suggested some questions that patients can talk to their doctor about, but with you as a nurse practitioner, what assessment tools do you use to kind of find out if patients are experiencing this type of neuropathy, which might be very unfamiliar to them? And then part B to that is, what do you suggest to your patients who are actually experiencing it to actually help build strength and fitness in themselves?
Okay, so you might have to remind me of part A and
I
part
will.
B there. So,
Don't you hate part A and part B questions? Go with the first one. What assessment tools do you use as a nurse practitioner to kind of draw out in patients that they might be experiencing something that they can't quite describe to you? What assessment tools do you use?
okay, so truthfully, sometimes I can tell from the minute the patient walks in the room, or I get them out of the lobby, whether they're having a problem with neuropathy, because they walk different. They walk, very gingerly. Sometimes they pick up their feet in an exaggerated pattern. That could be my first sign. But any patient that's getting neurotoxic chemo, one of the first things I ask them is, do you have any numbness or tingling in your fingers or toes? Because, you know, that sort of guides the conversation from there. And then if they do, I want to find out where it is and whether it's painful or not, and sort of take it from there. I developed a self-report tool that is used for research purposes when you really want to find out a lot of detail about peripheral neuropathy. But it's not something you would, and there are other tools like that that we use for research purposes. In terms of clinical practice, we don't always need to give patients a 59-item questionnaire about their neuropathy unless we're just very focused on that. But just talking with patients and observing them, doing a functional evaluation to see, first of all, there are some neurologic tests that you can do. For instance, vibration and pinprick sensation are two of the tests that you can do as a clinician to evaluate neuropathy. Reflexes are another thing that you can do. But for me, it's more helpful to evaluate how well patients can do certain things. Like I might have them button and unbutton their shirt or their zipper, and write their name on a piece of paper. Things that require either fine motor coordination in the hands or, more gross motor function in the feet. So I'll have them walk across the room, and if they seem stable with that, I'll have them, walk heel to toe or try to walk backwards or something like that. But you don't usually have to get that far because you can usually tell pretty quickly if somebody has neuropathy in their feet by the way that they kind of sway or lose balance when they're walking across the room, depending on the severity of it. And so, those type of tests are the most common, but really just talking with patients because about what they're going through at home is critical. And the questions that I said for you, for the patients to be able to make sure to discuss with their providers, those are the kind of questions that I ask patients when I see them in my clinic.
Okay. And then just lastly, do you suggest anything like for a patient who's experiencing this? Is there something that they can actually do to help build their strength and fitness, or is it something that you just kind of coach them through during treatment?
Well, there are many things that an individual can do. And again, it should be, something that's supervised, um, or at least recommended specifically for you. But swimming can be quite helpful. The patients in my support group all tell me that swimming helps them. And, I don't have any research studies to support that, but patient reports can be very important. And the Tai Chi as well. In some of my earlier work and this one study that I am sort of finishing up with right now and starting a new phase, I went to Washington State to meet with a physical therapist that works there with cancer patients. And the two of us developed this very specific program of strength and balance training exercises for patients. And we're doing a pilot study of that. And really, in the few patients that we've had in the study, we see tremendous improvement in their balance. And the type of exercises that we have them do are pretty simple and not high energy, don't really cause people's heart rates to go up. They're not aerobic type exercises. They're very sort of functional type things. Like, patients can stand next to a table so they have something to support them on in case they lose their balance, and do things like stand on one foot for as long as you can. And that helps. And then if you can do that for, say 30 seconds, then you could try doing it on a foam surface. Sometimes, the couch cushion would be something that, it's easier to do to balance yourself on a hard surface than it is on a soft, cushy surface. So, stand if you can do it with your eyes open on the hard floor, then try doing it on the foam surface, or try doing it with your eyes closed. Just standing, even outside of being able to stand on one foot, which could be really, really challenging and difficult for some people. And, I wouldn't recommend, if you have a balance problem where you know, need a walker or a cane, you shouldn't really start off with that. And you should definitely do it under the supervision of a healthcare professional. But you could, just stand with your hands at your side with your eyes closed and see if that makes, if you start to feel wobbly. These are really, really simple sorts of exercises that we've included. And then the TheraBands that you can buy at the most any sort of Walmart or anywhere else, they have these bands that are like big rubber bands but thick, and they exert a certain amount of force. So they could be tight, and then it would be harder for you to sort of get them apart. But you can work on the strength in your ankles and your legs by doing exercises with these TheraBands at home for really cheap, that will increase your leg strength. And if you increase the strength in your legs, then you have better balance, and you can, for instance, sitting on a low chair or getting up from a low chair or out of the bathtub can be very difficult for people with neuropathy. But if you strengthen those muscles, you'll have better control, and so you'll function better overall. And, I am happy to share those exercises with anybody that's interested in having more information about them.
Actually, Dr. Tofthagen, if we can get those from you, we'd love to be able to post them kind of as a recap from tonight's webinar. So I will connect with you tomorrow and get those from you if that's okay with you.
Absolutely.
Okay, great. So, first of all, I just want to thank you, for the clinical practice that you do every day for patients. In addition to that, for the research that you're doing to help patients in this area to help them have a better, improved quality of life. And then last but not least, most certainly, the time that you've spent with us tonight and sharing your expertise. So, thank you all to our attendees, to our IT people on the line, and again to Dr. Tofthagen. We certainly appreciate your expertise, and I hope everybody has a great evening. And if we didn't get to your questions tonight, it's just due to a lack of time, and we have them all here, and we'll be sure and address them with you following tonight's presentation. So thanks so much, everybody. Have a great night. Thanks,
Great.
Dr. Tofthagen.
My absolute pleasure. Thank
All
you,
righty,
everybody.
bye.
Bye.